Let's get started. Today we're gonna be doing SEVA VentRounds. It's September 19, 2023. Uh, and the topic is controlling or targeting tidal volume. And to some, this may sound like a common statement, say this is exactly the same thing, but it's not the same thing. And I think that we need to talk a little bit about this, and we'll see a couple of examples about it. Um, Here we go. So there's no disclosures. There's disclosures, no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. They are my conflicts of interest as well as Rob's Chatburns. We both are your hosts today. Keep your microphone muted. That just keeps the recording clean. And what we may, if you want to talk, just put it on the chat. We will call up on you so that we can have those conversations. And do remember that there's CMEs for CCF employees and there's CRC for any RT that is logged in. Just enter your name in the chat to verify attendance, and then there's going to be an evaluation that we will post at the end, and we look forward to you filling it up. We're happy to provide these CRCs. So the key SEVA knowledge, and I'll ask obviously Rob to comment on this, is that there's a difference when we talk about controlling volume and targeting volume. And this may seem as a simple item, but it's not necessarily it may seem as the same thing, but it's not the same thing. So when we talk about controlling volume, we're talking about the breath control variable, which is part of what we define as a mode. And it's what controls what we are controlling during the inspiratory period. So when the ventilator controls flow or volume during inspiration is when we say that this is a volume control mode. On the other side, there is targeting the volume, and for that we refer to targeting scheme, which is another part of the items that define a mode. But this, it refers to that the ventilator adjusts the output, in this case, inspiratory pressure, to deliver the target tidal volume. And in general, it's an average of a series of tidal volumes that the machine is trying to achieve the target tidal volume. Rob, can you talk a little bit more about this and clarify what I just said?
Yeah, so what we're trying to do is simplify and clarify the way ventilators work. If we were
Ariel, did he froze?
talking to and with speed control, excuse me? Can you hear me?
You froze for a second, my friend.
Okay. I keep.
It's the area where we live, Eduardo.
Yeah. All righty. We'll wait until Rob returns. Okay. So essentially, that's the difference. And I'm going to show you a couple of examples that will help you understand this better. But just remember, there's three components for modes of mechanical ventilation. There's the breath control variable, there's the breath sequence, and then there's the targeting scheme. And the breath control variable refers to what we control during inspiration. So it can be pressure or volume flow. And the targeting scheme refers to how the computer within the ventilator controls the output that the ventilator has. And in this case, it would be targeting the tidal volume. Rob, can you talk at this time?
Can you hear me now?
Yes, sir.
In simple terms, the control variable is one of the variables in the equation of motion. And there's three, right? Pressure, volume, and flow. And generally, we talk about controlling them within a breath. But a targeting variable is a particular value of the control variable, like tidal volume or peak inspiratory pressure or peak flow. And those are generally settings either created by the operator or by the targeting scheme automatically.
Very good. Thank you, Rob. All righty. So let's take a look at this graph from Ariel, and I put it here. So let's start with our tag, meaning the taxonomic attribution group. So what is the breath control variable? What is the breath sequence? And what is the targeting scheme? So just by looking at the waveforms, what do you think this is? And have no fear, put it on the chat. Very good, starting to come through. And indeed, this is a classic, and I see the majority of the group has defined this as volume control, CMBS. And what that stands for is that we're controlling flow, i.e. volume, and you can see how the flow is a square waveform, and so we're controlling the flow continuously, and that's why the volume, you can see how it increases linearly because the flow is constant. So the flow is going to increase in a linear way. Then it's CMB because that means that all the breaths are mandatory, so continuous mandatory ventilation. So every breath, even though it's triggered by the patient or a signal that the machine identifies as the patient, it's cycled by time. And because it's controlling the start or the end and the size of the breath, then it's mandatory. All the breaths are mandatory. And then finally, S for set point, which essentially means that the operator, meaning you, sets all the targets of the ventilator. So you put in what is going to be the tidal volume, what's the inspiratory time, what's the flow, what's the I2E, what's the respiratory rate. You enter everything. There's no intelligence built into this. It's just simply what you as a provider has chosen. So good job. So the next question here is, what is the load? So remember, if you are controlling inspiration, during inspiration you're controlling the flow, then you would look at the pressure waveform to try to determine what is the load, if it's resistive or elastic. Or you can look at the expiration and look at the time constant and time that it gets to go to baseline to define if it's elastic or resistive. And sometimes you may not be able to determine that because of PMOS is there. So go ahead, try to read this one. Enter your thoughts on the chat. So I see a series of people talking about elastic load. And then there's a question from Michael Smith, and he asks probably one of the crucial of this question is, does the load is affected by the presence of a leak? Rob, you want to comment on that? Rob, can you hear me? He's out. Okay. Well, Michael, let me ask the following question to you, which is, if there is a leak and you're inflating to the environment, what would happen to your resistance or compliance? Which one would be affected?
Well, I guess when you're talking about it, since your compliance is the change in volume over the change in pressure, and the resistance is the change in pressure over the change in flow, right? So the elastic load would be the one that would be affected, since the volume is being pushed out into the air. And my sense is that, again, if you're inflating the environment, then even if you have a higher elastic load, the pressure is going to be lower, and your flow is going to return to zero quicker because there's less coming back out to the expiratory limb, out of the expiratory limb.
Yeah. So both good Good comments, right? So the presence of a leak during inspiration is gonna, the pressure required to inflate the system, or that you're gonna see, is gonna look less because there's higher compliance. So that may affect, if the leak is present during inspiration, the total pressure. And then during expiration, now you would have lower volumes, but you more importantly, you would also have a higher compliance if that was the case. But in this case, you're not seeing that higher compliance. You're just seeing whatever it was left on the lung returning into the ET tube. And so that would not be affected by the leak. You would see how it returns back into baseline. Now, if it's massive leak, you may not see actually no flow coming back because all of it is leaking outside of the system. So great question. And I see Rob is still out. Any other comments from the team? So it's hard to see the load, but I presume that this is going to be an elastic load just by the air that was able to go through the system and go back to baseline in very short period of time. So it's probably elastic, and here we don't know. Yeah, it's very large. Thank you for pointing out that Ariel. It's a very large leak. Alrighty, so let's move on to the patient ventilator discordance. And let's see, remember, we always go in order. So let's see what the team feels is the issue with trigger. Is it normal, late, false, or failed? All right. So I have a couple of falses there, and I'll ask some comment in a second. Let's see, what do you think about inspiration? Is it normal? Is there over assistance, under assistance, or severe work shifting? Have no fear, just put your thoughts. This is a good testing for you to see how close you are to reality. Very good. So I see a couple of normals or several normals. All righty. And then cycle, what do you think it is? All right, the majority is saying normal. And then expiration, is there any evidence of work during expiration? Yeah, well, the majority of you see it as normal. Very good. So this is a very nice example that Ariel gathered. And there's a little clue here. There's several clues that are very nice to see here. So the first one, just going back to the elastic load and a manifestation of that elastic load, Mike, as you caused, is the presence of, you can see here, inspiration occurs, right? And then at the end, there's a pause. And you can see from here to here, that's called an inspiratory pause. And you know it's an inspiratory pause because the machine delivered the tidal volume, and then we did the pause, and there's no change in volume. I mean, we closed the valve, so the volume should not change. But look what happens to the pressure. So does this patient achieve a plateau pressure? I mean, normally you would expect there to be a plateau, and this should be continued to go like this until the next breath, until we'll release it, the patient exhales and whatnot. But you don't see that plateau. Instead of the plateau, you see how the pressure is decaying. And actually, it decays below the baseline, which would be the PEEP. As we have closed the valve, the PEEP, there is no more, the machine stops controlling the PEEP, and the patient can exhale below this. And that doesn't mean that the plateau is below this. It just means that the patient is leaking air. So you could not get an actual plateau for this patient. You And so that's the first nice teaching point of this slide. The second one is if we look at this machine is being triggered by flow, and we can see the pressure waveform, and we do not see any evidence of PMOS or very clear evidence of PMOS through it, nor during the flow, during expiratory flow, except on this one. This one seems to have some activity, perhaps, but I think it's just because of the tidal volume is so small of what is left on this patient that you just see that, but whatever. I don't see much PMOS on this patient. And then there's this little gray line that has a lot of tortuosity. And the reason is because this ventilator had the electrical activity of the diaphragm on to try to catch if there was any electrical activity of the diaphragm. And you can see essentially that there is no electrical activity. So this was a good case of false triggering due to a very large leak on the system. And so with the large leak, the patient, every time the air was leaking, and the ventilator feels that their patient is taking an effort. And that is because in flow trigger, what you have, if you imagine the circuit that goes into the patient, here's the ET tube. And so you have an inspiratory limb and you have an expiratory limb. And there's a constant flow that it's occurring from the inspiratory to the expiratory. And in the past, you could set how much that flow was. Now it does it automatically in majority of ventilators. In some, you can still modify that. And so if I'm putting out 1 liter or 5 liters, and the expiratory is going to be receiving 5 liters. But if I make an effort and air goes in, then the expiratory is going to receive less, and then the breath is triggered. But when there's a leak, now air is leaking from the system, and the machine is going to think that the patient is taking a breath, and that's where the false trigger comes. Comments? I don't see other questions. So yes, Mike, the large leak caused the false trigger. So how would you solve this? You have a couple of options here to solve the issue. The first option is to change from a volume, a flow trigger to a pressure trigger. That may sometimes work, although the patient is going to sometimes have to generate a lot amount of effort in the setting of that leak. Another one is to change to a mode that uses a non-airway signal like NAVA to trigger the ventilator. The other is to essentially recognize that there's going to be always a leak triggering this and change the patient to a mode where triggering is irrelevant. So, for example, on their PCIMB type 1, we could set up a trigger for the breaths or a respiratory rate, a baseline respiratory rate, and the patient will be getting that amount under pressure control and just do that. A big item that is important for you in this type of ventilation is when you have these large leaks and you're using volume control, you will be less efficient at ventilating these patients than you would be if you were on pressure control. So you will see that in general, we're more attuned to ventilate patients with large leaks with pressure control modes than with volume control modes, because of a large amount of the volume is going to be lost through the leak. And when you do pressure control, there's endless flow that you can inflate areas of the lung in spite of the large leak. Comments? Questions?
One comment about that is just because you're in pressure control doesn't mean that the patient is going to get the pressure that you have set on the ventilator. They get the pressure that is the pressure drop across the resistance of the leak, wherever that is. So if you have, let's say, an uncuffed tube, for example, there's a pressure drop from the trachea to the mouth, and that's the pressure that the patient gets. If you have a leak because of a chest tube, God only knows how much pressure the patient's going to get.
Exactly. All righty.
Eduardo, if I remember well, I think it was a case of deflated or broken calf.
Uh, I don't know. I think that this one said a bronchopleural fistula. But you know the case better, Ariel. All righty. Very good. Next case. Here's another case for you to take a look at it. So have no fear. What is the tag? And so let's walk through this. You can see the team is recognizing that this is pressure control, and we know it's pressure control just rapidly by looking at the flow. Every single waveform is different, and the pressure control waveform looks like a square waveform. So this simply, when there's different flows for each one of them, then definitely you're controlling pressure. Then you read it as CMB, and the key here for CMB is that none of the breaths that we see here are patient triggered. They are all being triggered by the machine. And we know that because none of them has changed color. In this ventilator in particular, it would change color whenever there was a patient signal achieving it. Even though we see a little deflection here, it's in general, all of them are machine. And so that immediately, if all of them are machine trigger, then this is continuous mandatory ventilation. And then several of you recognized a typical feature when seeing this. So if you're controlling pressure, you would expect, if this was set point, that all the pressures would remain at the same height regardless of the tidal volume delivered. However, here you can see that there's a breath at one height. The next one is a little bit higher. The next one was about to be a little bit higher, but you see another three that happened before that were even higher than that in the same setting. So this was the machine is targeting the tidal volume, and it will adjust the pressure up or down to achieve an average tidal volume for that patient. Rob, comments here, please.
That's a good observation. And the next thing we need to focus on is the distortions in the flow waveform.
Yes. So let's ask here, what do you think is the load? Can you determine the load by looking at these waveforms? Can you determine the load on this patient? Is it elastic, resistive, or do you see evidence of PMOS? What do you guys think? Is there PMOS? Is there no PMOS? So when I see these, I get a little bit, I try to go in order. So let's start with the first breath. So you see the device pressurizes, you see the pressure goes up and then reaches baseline really fast. And then there's absolutely no delivery of flow. Then the patient exhales and it returns to baseline really rapidly. Here there's a point that I always try to make a case for me to be aware of things. I like to look at the scales. And in this case, the scale is huge. It's 200 liters per minute. So that sometimes occurs. Remember, some of these ventilators have auto adjust, and it will go up and down according to what they're seeing to try to achieve the better scale for you to detect. So when I see this, I see this flow, but it goes up, but it returns to baseline very fast in less than a second, and here in less than a second. And I don't see any evidence of PMOS, the flow going higher or the flow going more negative. So in this one, I don't see any PMOS. I would say from here to here, I still don't see any PMOS. The next breath gets triggered. Again, small tidal volume returns to baseline. Exhalation returns really fast to baseline, nothing moving, no in and out. And you can see the tidal volumes down here are misers, very, very tiny. And so I would consider that this patient here on this, all this activity that I have highlighted from here to here, there's no PMOS right here. And with that, I would say that there is a very high elastic load. Just, it could be that they're biting the tube. It could be that the patient is exhaling forcefully, but there's very little air being delivered to that airway. Rob, these two breaths.
First of all, if the patient's biting the tube, that would be a resistive load, right? A high airway resistance in the upper airway.
Well, that's if not occluded completely.
Right. But, and that can happen if you bite the tube. The other thing is if they're breathing out, I would call that a PMUS load. It's just not in the usual inspiratory direction.
Yeah, but
so
you cannot
PMUS
see
is
it.
fighting against P-vent, and that's why you're not getting any tidal volume.
Right, but the ventilator doesn't see that. So the waveform right now, would you agree that it looks like an elastic load?
What I'm saying is you can't tell the difference between a high elastic load and an expiratory PMUS.
I understand.
There's no difference.
Yeah, I know, but there is no evidence right now of expiratory work right now here.
On inspiration?
And expiration.
Yeah, probably not on expiration, but yeah, well, that's true. I can agree with that.
Okay. So let's move to the next ones because there's other things here. So let's look at this waveform over here. Do you see any evidence of PMOS? And I would say that the next one, probably you don't see, it looks like identically to the other one. And also again, it returns to baseline within probably a second. So this is probably elastic load. And then you can see during expiration, the same thing occurs, not really much PMOS there. And so this looks like an elastic load. Now let's look at the last breath. Do you see, so again, through here to here, I don't see any PMOS, maybe here, but we're going to talk about that in a second. Now, what about this one over here? Do you see any PMOS? Yeah, you see the PMOS, right? So you see how it starts as a mandatory breath, and then it has the same configuration that these two. And then you see here inside that one, evidence of PMOS because the flow goes really high, and then the breath cut. And actually, you can see how the volume was increasing, and then it suddenly takes a really fast raise. So this one over here is an early trigger, as Lorenzo Oliveiro has pointed out. So I would say that there, and please, Rob, correct me if I'm wrong here, that at least on these breaths that I have number 1, 2, I'm not going to name that one, 3, and 4, that the load is elastic, at least by what we're seeing. Is that a correct statement or not? Please correct me if I'm wrong.
That's very plausible. And the difference between the first two breaths that are small and the second two breaths that are big, assuming there's no variable obstruction, would have to be just PMOS, right?
Yeah. Well, that may be it, or and some change on the patient condition, right? So pressure on the chest. I mean, I'm just going through a differential for this group of patients that we can talk about the potentials of why there is a change in the compliance for this group of patients. Right?
Yep, it's hard to tell from what we can see here.
Yeah. Now, when you see these things here that I have circled, that I'm circling now, what does that highlight for you, team, when you see this? So I see a failed trigger. Think a little bit more. Remember, the flow is moving away from the baseline. So usually when the patient tries to take a breath, you would expect this to cross the baseline and move up. Let me erase this because there's a lot of stuff there. Oh, wrong button. There you go. So let's do this calmly. So if the patient is exhaling, you would expect so normally you would expect the waveform to look like this, or actually like this one over here on breath number 3. If the breath is moving away from the baseline, that means that the patient is exhaling actively. So all of this looks as if the patient was exhaling actively. Then there's this breath, and then there's this exhalation. But at least there was some flow moving away from this patient actively exhaling. Actually, look at the volume get out of this patient, and if you can now actually, oh, actually this is a good example. This was the breath. It ended right here. So this breath over here is the continuation of this breath. I just realized that. So the patient had the early trigger and then exhaled forcefully during this period over here. Does that make sense, Rob?
Yep.
It's refreshing the screen, so I cut it in the middle. So there's one early trigger, but the rest are just mechanical. There is no, in terms of inspiration, do you see, guys, any problem? Is there any evidence of PMOS in terms of inspiratory PMOS? And I would say the answer to that is probably no, unless somebody sees any, but I don't see any PMOS anywhere during inspiration. This looks a nice exponential decay. So I'm going to say that this is normal. The cycle seems to be, I mean, if there's no PMOS, then there should be no delay. Actually, you see a little bit of late cycle, and then this one, but I would say probably normal. And then some expiratory work in a couple of breaths. Rob, comments?
Nope, looks pretty good to me.
So this is a complex image with a lot of information on them, but I think in general, if I was at the bedside, when you have these changes in tidal volume, the question is what is causing this delivery of flow to be impeded? And as Rob highlighted, the causes for acute changes in compliance are not many. Can you put on the chat, what do you guys think are the causes that change compliance rapidly on patients? And what I mean rapidly, this is essentially within 1, 2, 3, 4. So within 6 breaths. So Ariel comments on a pneumothorax. So it would be a large pneumothorax, perhaps. Other thoughts? A mucus plug. Yeah, an acute obstruction of one of the airways, so go into one lung. Rob puts coughing or patient movement, so proning the patient can lead to that. So for example, the sudden change of a patient from one position to the other, or activation of the expiratory muscles, or stiffness of the chest wall sudden, as said here by cough. biting on the tube or completely obstructing it. Obviously, the point that Rob made is important. If it's just kink, then you would expect some more of a resistive load. But if you obstruct it completely, then it becomes a compliance issue. Very good. Alrighty, so we have reviewed a series of cases. Here is the CME for our CCF caregiver, and then for the CRC for our Ts, you can use your phone to get that, or we'll put it on the chat in a second. There's a good question coming up. So there's how do you difference failed trigger during inspiratory phase and early trigger? Yeah, that's a good question, Victor. So during inspiratory phase, so I'm going to draw inspiration here for you, and I'm going to assume that we're looking at a patient on pressure control. So you would see this looking like that, and then the patient would exhale. All right. So if it's a failed trigger, you would expect the area where you would see, so let me put another breath here. Well, actually, like this. I just destroyed this one. So imagine there's another breath there. A failed trigger you would see during expiration. And so if you're looking at the flow, you would see the flow moving upwards, trying to cross the baseline and not achieving a breath. So failed triggers occur during expiratory phase, so failed trigger during expiratory phase. An early trigger occurs during it's usually a mandatory breath followed by evidence of patient activity during, and there's some discrepancy on the literature, but in general, what I think that we agree is that it happens during inspiration, definitely, or very early during expiration, meaning that the patient got the mandatory breath and then tries to trigger early on the next breath. And this has not been defined perfectly, but I think that what is uncontroversial at this point is that if you have a mandatory breath followed by patient activity during inspiration, there is no question on us that this is an early trigger, or also called reverse trigger. I don't think that that's necessarily true, Ariel. In an early trigger, there will continue to be there's different phenotypes of early trigger, and there's one that it happens with every breath, and that triggers the patient activity, and there's others that there's entrainment, and so you will continue to see activity of the PMOS on that patients. So Victor, the answer is yes. There's no failed trigger during inspiration because the breath has been triggered already. So if it happens, that means that that you're trying to breathe in during inspiration, and then we classify that as an early trigger. Now, one thing that we have seen commonly, and I will just highlight, is that there's patients that are having PMOS like this. They're having several attempts, and they're going at their own rhythm. And this may be the classic one is the patients with severe obstruction. So severe COPD, severe obstruction. And they're kind of weak, and they're trying, and you see the pressure waveforms, and what you're gonna see is just to show something, you may see then a pressure waveform, and then something like this, like that, and then during expiration you see this, and then there is evidence of the PMOS during inspiration and whatnot. And in this case, I think that what's happening is there's false triggers, but they're occurring throughout. And it depends which one you grab is how you're going to call it. And this is one of those major issues with any classification, is that what would you call this in reality? And I think that you probably if you're seeing all of these going through, this is mainly an issue of failed trigger rather than a reverse trigger. And I do actually have an example that I can show you really fast that may be useful for you to recognize that. So let me show you this example. No, no, come on, device from hell. This one. No. Well, oh yes, this one. So you can see here that there are several efforts occurring, and one of them occurs during the breath. So this is failed trigger, and this looks like a reverse trigger, but it's not a reverse trigger. So I hope that helps you figure it out. Yeah, so it's definitely a failed trigger, which is an asynchrony, Ariel. That's the definition. Alrighty, Rob, any final comments?
You said something really interesting, that if the patient bit down on the tube and there was a total occlusion, then it's not a resistive load. And that's technically true because there's no flow. There can't be any resistance, right?
Right.
So the only load that the ventilator sees is actually the elastance of the patient's circuit.
That's why I like you so much, Rob. You put it in such a nice words, so elegant, high quality. All righty. I hope that this was useful for all of you. Have a great day and keep learning. Bye-bye.